Registrations are now open for the 5th Bioceuticals Research Symposium to be held in Sydney on the 20th to the 23rd of April 2017. To register, please click on the Education tab at bioceuticals.com.au. This is FX Medicine. I'm Andrew Whitfield Cook. Joining me on the line today is Alessandra Edwards, who's a clinical naturopath, Western herbalist and nutrigenomic specialist with a specific interest in digestive health, mental health and their interaction with the microbiome. Alessandra's worked in the natural health industry for over 10 years, both in the UK and Australia, where she runs Reclaim Your Health, a busy nutrigenomic and nutritional clinic in Melbourne Bayside. Alessandra utilises an integrative approach to practice, combining specialised blood testing, genetic profiling and gut microbiome sequencing to formulate personalised healthcare plans. She works with a number of highly regarded integrative medical doctors and speaks regularly on nutrigenomics, gastrointestinal and mental health. Alessandra, I'd like to warmly welcome you to FX Medicine. How are you?
I'm great, thank you. Thanks for having me.
Now, you're down in sunny Melbourne, you're saying.
That's about right.
It's right this hour.
It is, certainly for the next 24 hours.
That's right. Now, we're going to be talking about something that can confound so many health professionals, indeed even medical professionals, and that's these quasi or facultative parasites that are Blastocystis hominis and Dientamoeba fragilis. So we're going to sort of start, I think, with let's delve a bit in about how you became first interested in parasites rather than just gut health, as most naturopaths do. Why treat parasites?
Well, that's a really interesting question. As you know, both, as we've talked about before, I think that my clinical interest has always been on gut and mental health. Mm-hmm. However, this particular focus on parasites really took off, I reckon, about 5 years ago. There was a time when I started to get a string of patients who were particularly treatment resistant. So their IBS symptoms, I was finding, were not responding to the usual dietary and herbal treatments. And it's around about this time that I started to become really interested in the field of nutrigenomics. And that was about the time when PCR technology for detection of parasites in stools really took off in Australia and was becoming widely available through the Medicare. So it's something that, if you like, I kind of fell into. And then I started to get such amazing clinical results from my approach to parasites that over time it's really become part and parcel of what I do really on a daily basis.
So I need to sort of cover this straight off the bat, and that is that, you know, there's this interest in parasites as even treatment nowadays, but then of course there's an infestation where they cause symptoms. So when do you bother, I guess, treating parasites? When do you look for them as a problem rather than just part of the normal commensal microbiota?
Okay. Well, I think that you have to really look at the clinical presentation for that. So I'm not someone to just go into treatment lightly. And I find that I really have to take into account where the patient has come from. So just to give you an example, on a daily basis, I see a couple of different types of clients. One is the type of client who's had chronic digestive symptoms and has seen a number of specialists, both complementary and traditional. But the parasite diagnosis has been missed. So we action some tests and we get the results.
Yep.
if they do come back positive for the parasite and they have very chronic, severe symptoms, that's when I decide to treat the parasite specifically.
Right.
The other type of client I see is one who has been diagnosed with the parasite, and they have either been prescribed sort of what called the frontline treatment by their well-meaning GP. So first-line treatment in Australia through a GP for blastocystis and entamoeba usually is flagyl or metronidazole.
Yep.
Usually they're not responsive, so some of these clients then have gone on to see different specialists and have gone down the route of doing triple antibiotic therapy, usually orally followed by colonic infusion. So these kinds of clients I see, often they no longer have blastocystis or the entamoeba. Sometimes they still do, despite this approach, but inevitably they still feel really unwell. So they have really chronic symptoms. So in these clients, if they still have the infection, I don't treat the infection. I treat the person and I treat their digestive system.
So what sort of parasites are we mainly looking at here?
So the main ones that I see in clinic are definitely Blastocystis hominis and the Entamoeba fragilis. They're the two main ones, but blasto is by far the most common one I see.
Right.
I then see a small number of people who present with both co-infections. And this is also followed by post-antibiotic treatment giardia. So the giardia is gone, but again, the symptoms are still as during the acute infection.
Yep. And what are the major presenting symptoms that you tend to see? You know, as you mentioned before, you can see some sort of vague things and then these chronic, vague chronic symptoms, but then sometimes people can present with a quite severe sort of overload.
That's right, yes. And this is what is so confusing, I think, for many complementary practitioners, is the fact that many of the symptoms that come with these infections actually can be symptoms that are related to other conditions.
Right.
So generally speaking, I see some milder symptoms which, are quite non-descriptive. Could be things like nausea, general fatigue, headaches are quite common, anorexia, so loss of appetite, halitosis. These are really the main sort of vague symptoms. And then usually they're accompanied by more severe symptoms like diarrhea and constipation, which is, I'd like to mention constipation because I find when speaking to colleagues that most of them associate blastocystis and the entamoeba infections with diarrhea, but actually I see chronic constipation really often correlated with these infections. And the other thing is also alternating bowel patterns and occasionally vomiting. But if I had to pick one symptom that I would say is the most common that I see across the board is abdominal pain.
Okay. So that clears something up for me because, a lot of these sort of symptoms, they're rather ambiguous. When you're talking about headache, allergies, things, how do you blame them on parasites versus something else? How do you tease that sort of thing apart? I mean, this has always been my chagrin, if you like, is how do you know when to say, I think there may be something to look further into?
Absolutely. Well, I think my answer to this might be a little bit biased in the sense that I tend to see those clients who've done the rounds,
right, yep,
in terms of specialists and practitioners. So I have sort of this inherent bias that it might be a parasite. So generally speaking, I test pretty much everyone I see who has a combination of vague symptoms and chronic digestive symptoms. So that's generally my approach, and particularly because it is fairly easy to test. And whilst it's not the most pleasant test that you can request for a client to do, it is, easily requested and available through Medicare. So I always think, let's not waste time beating around the bush. Let's rule out the parasitic infection from the beginning.
Yeah, I think the thing is you're not beating around the bush. They've already been around the bush.
Well, that's right. Often they have been around the bush. That's right.
And speaking of bush, I've got to ask, particularly with blasto, like it's rife throughout the northern rivers in New South Wales. I've got to ask, is it in the water supply? Like, is it these people who drink rainwater and they're not treating the water properly, or where do they get it? How do they catch it?
Yeah. Blastocystis is ubiquitous. So I reckon that about 60 to 70% of my practice base actually has had an infection with a parasite at some point or other. So exposure is definitely a big factor, given that it's so ubiquitous. So blastocystis is usually transmitted by either eating contaminated food or drinking contaminated water.
Right.
So red flags and alarm bells really go off for me when, as part of the initial conversation or the initial questionnaire that I send out to clients, is when they tell me that they drink tank water,
Yep.
or that they, some of their relatives have tank water and they see them regularly at weekends. I find I have a lot of clients with whom I consult via Skype in northern New South Wales, so the whole of Byron area.
Yep.
It is not a myth, I have to say, and I think it's because, generally speaking, that community is quite aware of wellness practices and environmental practices. And so most people there have got tank water, but they're not necessarily aware of the fact that you should have a good quality filtration systems and have your tank water regularly tested and treated. The other thing I wanted to say is that's really common is overseas travel. So really, particularly travel to Southeast Asia. And that is because I have a hunch about this. I think that these parasites we know are endemic in those areas.
Yeah.
But secondly, I think is that when we travel to those countries, we're actually exposed to different bacteria, which are non-parasitic in nature. And so I think that kind of disrupts somewhat our own internal microbiota and probably leaves us open in terms of crowding out the parasite. And so that's just the theory that I have. So I generally advise traveling with a number of tricks up their sleeves to prevent this. So in terms of strain-specific probiotics, prebiotic fibers that have been shown in the research literature to be protective against gastroenteritis, because that's the other thing that we often see is actually secondary parasitic infection following on from gastroenteritis that has occurred as a result of overseas travel.
Yeah. Now, you mentioned strain-specific probiotics, but indeed there may be some part of this puzzle to do with strain-specific parasites. Is that right?
Absolutely. And I guess that takes me a little bit into the realm of research. I think there's quite a bit of misunderstanding in terms of the research that's available about these parasites. And so what we know in terms of the research is that there is no consensus as to whether blastocystis is purely virulent in terms of the parasite or whether it is a pathobiont. What I mean by that is that potentially blastocystis could be an organism that could actually live quite happily in symbiosis with our microbiota in our digestive tract, but has the potential to go bad. Now, at this stage, we don't know why in some people it goes bad or not. And what we do know from the research is that there are many subtypes of blastocystis, but again, the consensus as to what that means isn't there.
Yeah.
What we know for sure is that subtype 4, for example, is most commonly associated with chronic diarrhea, so more difficult, more chronic symptoms.
Yeah.
But other subtypes like 1, 2, and 3 have actually been found both in asymptomatic cohorts as well as symptomatic people. So we don't really have an awful lot to go on at this stage. And I, for one, don't actually worry too much about the subtypes. So my treatment approach, because there is one kind of test that you can do in Australia that looks at some of the subtypes, not all of the subtypes. And really, I think that if you base your treatment strategy on the clinical symptoms and the medical history, then you really shouldn't have to worry about the subtype.
I love the word you use, pathobiont, because it's a sort of juxtaposed sort of term rather than symbiont. We have a pathobiont, so it's a pathological agent under certain situations or criteria. One that I've got a little bit of a flavour for is these segmented filamentous bacteria, the SFBs. But it's really interesting that you say that it could well be that it's the terrain that we set up around it that causes it to go, oh, hell, I'll live in that. Is that where your sort of treatment sort of lends itself to?
Yes, absolutely. I'm so glad you've asked me this question, because this is what I'm really passionate about as a clinician, and I'm really acutely aware of the debate around blastocystis, and it seems to me very polarized approach that we either treat or we don't treat. So antibiotics are bad and this is good, and I think that again, this is what as naturopaths and herbalists we are so good at. This is what we have to offer our clients, in the sense that I think you need to ask yourself your question as a clinician: what is the path that your client has followed in order to be where they are today? Why is it that some people are symptomatic with blastocystis and others quite happily can coexist with this parasite all their lives without having any issues? And in fact, some of the new research that's coming out around blastocystis, which is what I find exciting, is that they're now starting to look at the microbiota diversity index in people who are affected by blastocystis opposed to those who don't have the infection. So I think that that's really, really interesting. So in terms of the question you asked me, my approach is first and foremost taking a really good history and doing a good physical examination. I think that this is probably the most important determinant factor in terms of how I select the treatment. So what I'm thinking of in terms of, specifics is you need to ask questions related to their birth. Did your client have a birth that was C-section, or were they born vaginally? Were they breastfed from the beginning? Were they bottle fed? Was their mother affected by group B strep, and therefore did she have antibiotics given at birth or in the first 24 hours following the birth? These are things that are going to start giving you an indication as to the kind of ecosystem that is in that person's gut. And following on from there, finding out about the family history, are there mental health issues, is there a history of atopy, digestive issues? Growing up, what was their family diet like? I mean, we know that an individual's microbiota for life is established in the first 3 years of life.
Yeah.
So those are really important indicators, because microbial diversity does not change throughout life. What you're born with is what you've got. Now, you can enhance it and optimize it, but understanding where the nurture points for your clients are going to be really important. And then understanding their current toxic environment. So, for example, do they use herbicides? Do they use pesticides?
Yep.
Do they eat organic food? Are exposed to a daily intake of glyphosate? Do they filter their water? Are they drinking a lot of chlorine? All these things are going to have a huge impact on their general ecosystem. And for me, in terms of my clinical experience, I have found that restoring this ecosystem through a number of techniques is what makes the huge difference. And sometimes we actually end up clearing the parasite, even though killing the parasite per se was not my number one treatment aim. My treatment aim was to restore digestion and the ecosystem. And then we retest, and the parasite is just spontaneously gone.
Now, this is something I love the way that you say that, because I've so often have an issue with this kill approach, this sort of switch mentality. It's almost like a knee-jerk reaction to things. And I'm so glad to hear you talking about terrain and these results that you're getting. But I've got to ask, though, with regards to the medical approach, of course, a GP, a gastroenterologist, will want these sort of definite things to treat and a definite result from a treatment, or else it's like, well, why am I treating? And I've seen that, even like Professor Tom Borody says, look, if there's no difference, I'm not going to treat, because what difference am I going to see? You know, so he's sort of in a quandary there. Whereas what you're talking about is saying, well, how about we get the digestion back, and it may be that the parasite just goes away.
I mean, at the end of the day, the reason why people want to clear the parasite is because they want to be well.
Yeah.
Sure, in a minority of cases, I do get the odd phone call when people are absolutely adamant they want to get rid of the parasite, and they ask me, will I treat them? So then I start asking them questions, and they're completely asymptomatic. They don't exhibit any symptoms of an impaired digestion. And so inevitably my answer is, no, I'm actually not going to treat you in the sense that I'm not going to give you antimicrobial herbs. But I'd be very happy to help you continue optimize your digestive symptoms, your digestive function, so that you don't end up developing symptoms as a result of the parasites. And I think that whilst my approach is very biomedical, and I like testing, stool testing, blood testing, and all of those wonderful
measures.
techniques, objective measures. At the same time, I think it's important to remind ourselves as to why we are naturopaths and why we're called naturopaths and not gastroenterologists. So I'm not here to judge their approach. I work with a number of specialists and doctors, and I think that most of them do an amazing job. But they certainly don't have this bird's eye view that is unique to naturopaths. So I really just encourage people out there to even use mind mapping, whether on traditional pen and paper or getting yourself an app that does that, and starting to think laterally and putting all these things together, because that's where really our strength shines. And the results that we can get are incredible.
Yeah, and indeed with the medicines, as you spoke about right at the beginning, Flagyl being one of the first-line medicines, they're showing resistance to this, right?
Absolutely, yes. And this has been shown time and again. And yet, unfortunately, many GPs are not aware of this. So, unfortunately, this is quite a difficult conversation that I often have with clients, particularly if they've had the same GP for a number of years and are quite attached to that, because I tend to suggest going to see someone else who I know is a little bit more versed in recent research. But, yeah, certainly that is problematic, and particularly the indiscriminate use of Flagyl over recurrent courses, and particularly in children. So you end up seeing these cases where, unfortunately, the blastocystis or the entamoeba are still there, and their stools are far worse than before they're treated. So it's instead of a win-win approach, it's a lose-lose approach.
Yeah.
As I say, yeah.
Now, is there any way to tease apart with a symptom picture an infection or an infestation or an issue with blasto versus Dientamoeba fragilis?
Oh, that's a great question. I'm not sure about that. Not something that I have noticed. Perhaps in terms of virulence, I would say that blastocystis can be stronger. So in terms of really chronic resistant cases with severe diarrhea and constipation, for me is more looking at particularly the age of the client. That's really important, because we know that the entamoeba is more common in young children and toddlers.
Right.
And that certainly seems to be true in my clinical practice. I see a lot more of that parasite in toddlers and children around the age of 5 to 8. Whereas blastocystis seems to become more common from teenage years onwards, and the incidence increases with age. Now, we don't know why that's the case. I think it's probably due to a number of reasons. One, we know that blastocystis continues to reproduce and colonize throughout life. So unless you're taking these measures that I was talking about earlier in terms of restoring the ecosystem, blastocystis is just going to increase and increase. Now, because it's so ubiquitous, it goes without saying that as we age also we're exposed to it more. And the other thing is that we know that gut microbial diversity decreases with age.
Yeah.
So, and also there's the phenomenon of immunosenescence. So I think that all these factors are contributors to why blasto is more common in adults than children.
Now, I just need to cover off, and I'm probably sort of backtracking a little bit here when you told us all about the symptoms, but I'm just hooking into things like a possible link with irritable bowel syndrome. And, there's to me, this is new. To some practitioners are much more versed in this than me, but that's small intestinal bowel overgrowth, or SIBO. How do you tease apart an infectious nature versus a non-infectious nature?
Well, I often see the two go hand in hand.
Right.
So the two very often coexist, and this is why testing is particularly important in these cases. And so, in terms of symptom picture with SIBO, I particularly see pronounced bloating as the number one presentation. But of course, there have been cases where, bloating hasn't been the number one presentation, but constipation has been more predominant. Generally speaking, again, going back to what I was saying about the terrain and the ecosystem, when I see these symptoms in terms of changeable bowel movements and bloating and pain, I'm basically on the alert in terms of what could be going wrong all the way from mouth to anus. So it's a matter of asking the right questions and taking the right history.
Yeah.
So, for example, with SIBO, there may be discomfort that occurs very quickly after eating. There may be bloating that occurs very soon after eating. And there may be a history of PPIs, for example. There may be a pre-existing infection with Helicobacter pylori, ongoing use of NSAIDs, for example. All those things are going to be risk factors for SIBO. Practically speaking, again, I usually rule out, if I feel that SIBO is a differential for me, then I will refer to the GP to get the fecal PCR multiplex to rule out the parasites, whilst at the same time I refer privately to a breath testing clinic to rule out the SIBO. So the approach is multifactorial, and we would basically approach the SIBO first, and then start working on the parasites. And I think it's important to approach the SIBO first because it can basically perpetuate a cycle of inflammation and poor motility that are going to negatively impact what I'm trying to do with the treatment. So when I'm treating parasites like Pathocystis, I modify the diet quite considerably to increase levels of prebiotic fibers. So I recommend a high fiber diet. And so if there is a dysmotility picture, it's really important that we address that first.
And how do you sort of mesh that, if you like, with the low FODMAP diet in IBS use and things like that? When do you tease that apart? And
so, if the client has been, I don't necessarily put everyone on a low FODMAP diet. But if the client tells me that they have actually they feel better on the low FODMAP diet, then I use manufactured prebiotic fibers that are compatible, whilst maintaining the diet as a low FODMAP diet, adding sort of these supplements that don't cause disturbances.
And do you use natural medicines as an adjunct to some antimicrobials, like dare I say the word selected antimicrobials, or do you choose to only use natural medicines because they've already been there, done that with the pharmaceutical antimicrobials and they haven't worked?
So if they, again, it depends. It depends on the individual. So if they've had the antibiotics, particularly the triple therapy, and the blasto or gentamoeba is still there, which incidentally I do see. I know it sounds incredible, but I see this. Then I do not give antimicrobials. So I will give selective antimicrobials that are actually very gentle. And at the same time, we do all the gut repair. So with prebiotic fibers that are rotated, this high fiber diet, high polyphenol diet, and specific probiotics. So that's generally my approach.
Yeah. Now I need to ask about the specific probiotics because, just like pathogens, naturopaths are very, very well versed in strain-specific probiotics, but not for strain-specific pathogens. But there is use for certain strains of certain species of probiotics to get a certain defined response, if you like. So which ones do you use, and has anybody researched any of this?
So my preferred strain for addressing parasites is Saccharomyces boulardii and the Biocodex strain specifically. And the reason I selected that one is because it is one of the few ones that has actually been researched. Now, there isn't an awful lot of research on it. And I have to say that, again, the studies on it are a little bit confounded in the sense that very often when they do these trials for Blastocystis intervention, whether with Saccharomyces boulardii or antibiotics, they, in my opinion, they test too soon after treatment. Mm-hmm. And they also usually retest using the wrong techniques, so just microscopy and culture.
Right.
And I think that often you do get, good results in these trials. Even metronidazole, Flagyl has had positive results in the literature, but I think it's because possibly the counts are being reduced, and so then the microscopy and the culture are not really picking up.
Yeah.
However, I have been using this strain for quite some time now, and I think it's incredibly well tolerated, and the results are really, really great. The other strain that I use, not specifically for addressing the parasite directly, but more for fostering the growth of beneficial bacteria, is Lactobacillus rhamnosus GG. So they're the two main ones that I use initially, and then after doing initial protocol, about 6 to 8 weeks, I can select different strains according to how the symptom picture is changing, so as to whether I need something that's more immunomodulatory, or if there is a mental health picture with anxiety, then I might select a different strain.
Right. Okay. And do you use, look, I guess this is a piece of string question, but can you give us a general time frame? I know that's something that we shouldn't really ask because every patient's going to be different, but can you give us a general idea of what sort of time frame you're looking for results?
Yes. So if the client is treatment virgin, as I call them, in the sense that they haven't come after Flagyl, then I would say 6 to 8 weeks. So this would be on rotational herbal antimicrobials and then the stated probiotics that I've said and prebiotic fibers. And then I might follow with another, 4 to 6 weeks of prebiotic fibers and continue to increase the dietary variety, which is the hardest thing to do. So usually start by introducing very small levels of lentils, very well cooked in minute quantities. And then I usually wait at least 6 weeks, and ideally, if the client will allow me, wait 8 to 10 weeks before retesting, provided that they're not going to be travelling overseas in that time or going to Byron Bay.
Yes.
In which case, I advise if we can retest before they go, because otherwise you don't know. So that's the sort of the treatment virgin case. Now, in the case of clients who has had extensive treatment before, or who have just general chronic conditions that go with it and have had severe food chemical intolerances for a long time, then treatment can be upwards of 1 to 2 years for sure. And when I say that, I mean that there will be a step-by-step gradual improvement in the symptoms. So, for example, the diarrhea might go, or the constipation might go. That goes fairly quickly. But in terms of being able to reintroduce a really broad variety in food groups, that's the trick. That's the thing that takes the longest in these clients. And
I guess I have to ask you to go through for our practitioners any red flags to look for, the obvious ones, but also maybe some more grey areas where you might go, aha, something's going bad, something's going on.
Yes. I'm personally very integrative in my approach. So I always refer all my clients to a GP every time. So after the initial consultation, everyone will be referred back to a GP. I do this for a number of reasons. Number one, I think it's good practice. I didn't attend medical school, so I feel that from a medical diagnostic perspective, I need to be safe. And so for best duty of care in terms of my clients, I always refer. So I think it's important to always write a good referral letter that is appropriate and succinct. So that's something that I recommend that you always do. But in terms of actual flags, I would say the most important ones that you have to refer straight away would be blood and mucus in the stool, absolutely, and really severe acute abdominal pain accompanied by fevers, particularly, clammy sweats.
Yep.
When there is weight loss that has been going on for some time, sarcopenia should always be referred. Things also like severe night sweat would be pretty important to not to ignore.
Yeah.
And I think that just the one thing that I like to say is that, I've in the last few years, there's been an explosion of forums related to natural health that are available to us practitioners, and I think that is fantastic. But at the same time, I'm a little bit dismayed by the attitude that I tend to read on a regular basis in terms of the disparaging comments of doctors. And I have to say, I think there's good doctors and bad doctors just as much as there's good naturopaths and bad naturopaths. And I think that we can gain so much by fostering good relationships with doctors who are open-minded about having a complementary approach. You really end up having the best care for your client.
Absolutely.
And in that way, you know that they're going to be safe because these red flags are not going to be missed. And at the same time, I find that these doctors who are open-minded are absolutely delighted when you can take off their hands these very difficult clients who are not getting better just on a low FODMAP diet, where they've referred to a dietitian. So that is just my one piece of advice as to how you can grow your practice, because you will also get a lot of referrals from these doctors who are desperate to get some good practitioners to help them with these, vague chronic cases.
I totally agree with you. And, I was one of these closed-minded standard health care practitioners. I was closed-minded as a registered nurse. And notwithstanding that, there are some medicos that are just closed-minded and you're not going to get anywhere, I think we have to realise that if you want to walk a mile in their shoes, be a doctor. It's not an easy
Absolutely.
job.
No, it isn't. It isn't. And really, just like everything, I often see clients who've come from a different complementary practitioner, and I don't agree with the treatment approach they've taken. So I think being open-minded is the thing that's most important. And absolutely, there's many GPs who, as soon as they see a referral letter coming from a naturopath, they don't even read it. And that's fine. So you just learn your lessons and you don't refer to that GP anymore. So
Yep.
What I'm saying is just put the effort in, go and visit some GPs, maybe try some out in your area for yourself and see what you think. Have a chat with them as part of your consultation for yourself and ask them whether they'd be open to you referring some clients to them and see what their approach is.
Now, I have to ask, have you written books? And if not, why not?
Oh, this is what my mentor asks me on a monthly basis. I think, no, the answer is categorically no. There is one in the pipeline related to gut health and mental health and the connection between resilience and gut microbiota. It's a particular interest area of mine. Just like everyone else, I think, who runs a busy practice and has young children, time. So the moment I can find that time machine, there will be many books coming your way.
Yeah. So the next question, I guess, is for practitioners to gain a better understanding about how to manage patients with these sorts of issues with the parasites. And notice I didn't say treat the parasite necessarily, but how to manage these sorts of patients. Where can practitioners go for really good information?
There are some really great people out there. My mentor is Jason Horolak in Tasmania, and he's just an absolute wealth of both intellectual knowledge and clinical experience. So any courses you can do through him, I would highly recommend that. You can also look him up on YouTube, and he's done a number of talks and lectures. So that would be my number one approach. There are also some online courses you can do through Health Masters Live, which are always very informative. And at the end of the day, I think also not forgetting your research skills, because we've got access to PubMed, Medline, and so keeping up with the research in those fields is really, really critical. And not forgetting the traditional approach. So, there's some great books on traditional herbal medicine and starting to utilize, those particular herbs. That's really, really, I think, a great approach.
What about, I've got to ask, what about some of the old texts like the herbal texts like David Hoffman? Do you ever use those, or do you tend to sort of steer towards like Kerry Bones?
No, I do, and I go through phases actually, because you tend to forget things, and I think those books are amazing, and I do like sort of the old classics. So I basically tend to do a mixture, and sometimes when I feel that I've kind of forgotten some of the fringe aspects of a particular herb, for example. So I'll just sit down of an evening and just go through and leaf through these wonderful classic textbooks. So I think that's a great point.
Excellent. Alessandra, I can't thank you enough. You've really opened my eyes with regards to a few things that I kept on getting confused about. Well, what's the relevance? How do I know that it's this and rather than that? But I got to say, I really do love that you treat the patient and you look at the terrain rather than just honing in and trying to kill the poor little bug that may or may not be the baddie. So I guess that's an oversimplistic term. So really thank you for sharing your wealth of experience today with us on FX Medicine.
Thank you so much. It's been an absolute pleasure.
This is FX Medicine. I'm Andrew Whitfield Cook. 2016 has been a great year for FX Medicine. We've celebrated the first anniversary of our dedicated website, fxmedicine.com.au. And we're also very honoured and proud to be the recipients of the Complementary Medicines Australia CMA Award for Most Outstanding Contribution to Research, Education and Training. We love bringing you relevant content which is designed to improve safety and clinical proficiency. We're so very grateful for your continued support, and please do let us know what topics you'd like us to cover in the future by dropping us a line on fxmedicine.com.au, Twitter or Facebook.